In today's video, we're going over 4 keys to non-operative rehab of rotator cuff related pain. Whoa! Who's this right here? We have another guest right now on the Fitness Pain Free Show. Who's this?
I'm honored. I'm Kevin Coughlin, your coworker at Champion PT.
Yeah. Guys, sorry for the interruption, but we have a really cool new addition to the podcast. This is Kevin Coughlin. He's another physical therapist. He's an excellent physical therapist. Actually did your internship or clinical affiliation at Champion. How many years ago now?
Yeah, that was in summer of 2018. So in
Dang.
some ways it doesn't feel that long ago, and in some ways that is quite a while ago.
Yeah. Well, Kevin blew us away with his knowledge and his expertise. We ended up hiring him. So now we work together at Champion. Kevin's a great guy. He's super smart. I always admired him. He has great communication skills. I think he has a lot of great empathy. He really likes to learn a lot. And we both love fitness. So we kind of jive, I think, from that perspective. We live in the same town, Maynard, Massachusetts. Wonderful place, right? Birthplace of Amory Maynard. What a great spot.
Yeah. Great spot. Yeah.
Go ahead.
I'm just gonna say I'm honored to be here, Dan. That's all very humbling, and I really appreciate that you feel that way, and I appreciate how you said it. I'm happy to be part of the Fitness Pain Free podcast because I feel like I am the avatar that you make content for. I've been consuming your content, and I remember when I started Champion telling you have to start a podcast, and I've probably listened to every episode. And I think I'm super lucky to work with you and work with all the other great PTs at Champion. So I almost feel like I have a duty to be on the podcast because I think I will ask you questions that a lot of our listeners are always wanting to ask you. So it's almost like we just have an avatar of your listener on the show. So hopefully I can bring some insight and just kind of show you guys what I'm learning over at Champion, but also be there to ask Dan the questions that a lot of us are wondering as you're making these podcasts. So I'm super excited.
Yeah, that's a really good point. Basically making the podcast for Kevin.
Yeah, exactly.
Cool. All right. Well, I'm really pumped for today's podcast theme here, right? We're going over 4 keys to non-app rehab of rotator cuff related pain. And got a little outline for you. We're going to delve right into it. So I think that the most important thing to start with your patients is making sure that you have an accurate diagnosis. Because if you're treating the wrong thing with the wrong treatments, then you might not make any progress, right? So I think that's important. I don't think you need to be super specific with your diagnosis. I don't know that we need to know exactly like this is a supraspinatus tendinopathy, and it's not like an infraspinatus or biceps tendon. But I do think you have to rule out weird pathologies that have a different treatment. And I think the big one that I'm thinking about for most patients go through door is going to be radiculopathy, right? Is there something going on with the neck that's creating shoulder issues? And I think the big one is like a C5 radiculopathy, because these folks tend to have pain around the shoulder region, which is usually where folks have rotator cuff related pain. They'll often have some weakness in the deltoid, which you see with these large and massive rotator cuff tears, right? You see a bit of a shrug sign in those folks. So just make sure that you're not dealing with some sort of cervical radiculopathy. These are funky because oftentimes the arm pain is worse than the neck pain. So sometimes the neck doesn't hurt and they've got a bunch of arm pain and ends up being something neck related. But rule that out first. The second one is going to be some sort of frozen shoulder. Just because frozen shoulder is generally treated with range of motion, oftentimes a cortisone shot is really helpful. Maybe you want to call the doc back up, get him back in for a cortisone shot before you start with physical therapy. And then your exercises tend to be more flexibility based. Although flexibility is also helpful for rotator cuff related pain, you're probably going to do more range of motion for a frozen shoulder than you would for some sort of rotator cuff related issue, right? To go along with this video, I have a free cheat sheet for you. It is an evidence-based cheat sheet for rotator cuff related pain. I'll give you all the knowledge to go from a beginner to a master in understanding rotator cuff related pathology. We go over the prevalence of these conditions, as well as the anatomy. We talk about the difference between tendonitis and tendinosis. We chat about risk factors increase your likelihood of getting rotator cuff tendinopathy and tears. We talk about the clinical presentation of this disorder and also which tendons are most commonly involved. We talk about the different stages of pathology and whether or not the rotator cuff tear heals over the course of time. Next, I give you the bullet points about rehabilitation expectations. We round out the PDF with some surgical guidelines, which your patients should go on to get surgery for rotator cuff tears. So I'm going to leave a link in the description, in the show notes. Again, this is 100% free. Go ahead and download this right now.
Yeah, I'll just add in here that, having worked with you for a while, I'll say that you truly do check these things on people. I'll overhear you, and, I've tried to pick up the same patterns, right? But someone comes in with, sometimes we get fooled by a script. So someone might come in with a script that says rotator cuff pain or subacromial impingement. And a lot of times it's easy to just assume that's what's really going on and get right into treatment and talking to the patient about what this could mean for them. But you do really want to be thorough here. And, I'll often hear you ask the patient if they have any reason to believe that this pain is coming from their neck, any history of neck pain. So get a little subjective history with that. For frozen shoulder and in that type of diagnosis, maybe they have some comorbidities that we want to look into. Diabetes, some type of thyroid issue sometimes can predispose people to that. So we do want to be thorough in the subjective. And then one thing I tell our students often, and I know you're really good about this, is when we go through the objective assessment, we always want to start top down, right? So if I see someone with a shoulder pathology, we're screening their neck. We're looking at all the cervical range of motion, flexion, extension. If we think there's any possibility that the cervical spine is involved, I'll look at repeated motion. Is that kind of what you look at as well to rule in or rule out maybe some of those special tests? But I find repeated motion to be pretty good to see if it's bringing on their specific complaint of shoulder pain, because sometimes they might have a little neck thing, but it's they're telling you it's not the same pain I usually feel. But do you look at repeated motion, people?
Well, not too much. I mean, I guess you're talking classically about like McKenzie kind of repeated motion. I don't. I just screen cervical range of motion, and I'll do a bunch of special tests. You know,
Sure.
um, I've heard a lot of physical therapists I really like and trust say they use repeated motion, and it does make sense to me. But then I tend to go back to trying to be a little more evidence based. Like if someone has a cervical radiculopathy, what are the most sensitive and specific tests for cervical radic? And I tend to go with those. I think a dead giveaway is numbness tingling, right? If they're having broad pain, kind of down their shoulder blade type deal, anything down the arm, numbness tingling. Yeah, that's a big one, but they'll probably do an upper limb neural tension test, maybe some Sperling stuff. But largely, I'll ask the question to the patient: do you think your neck is related to your pain in any way? And then I'll just do range of motion testing. Then I might do some special tests, right? And then I'll start doing some special tests for the shoulder, and then we'll kind of see, does it seem more necky or more shouldery, right?
Yeah, totally.
Yeah, funny. Yeah, and after we've kind of rolled out those things, I also tend to think about shoulder instability, just because I think that shoulder instability has a slightly different type of treatment than rotator cuff related pain. And by shoulder instability, I mean kind of this frank instability in either, let's say, external rotation, horizontal abduction, so more of an anterior instability, or posterior instability with arm across the body. And I think you pick up a lot of this in the subjective. If people have said they had a dislocation or subluxation or feels unstable, right? That's another giveaway. And I just think that's important, because if I do have someone who had, let's say, a dislocation of the shoulder, that's obvious as instability. But if someone does have some sort of anterior instability, I may want to stay away from end ranges of motion a little more so, just to protect that joint. Whereas if I have someone with rotator cuff related pain, I'm probably going to push to end ranges a little bit more so, as long as it's feeling okay, right? But I think the big takeaway is that if someone has like shoulder pain, it's probably going to be treated very similarly across different diagnoses. So if someone has, let's say, infraspinatus, supraspinatus, maybe subscap is a little different, but you're still treating it similarly. If someone has a slap tear, if someone has bicipital tendinopathy, they're all going to have a very similar treatment. So I think the big one is try to figure out if it's some sort of diagnosis that's like completely unrelated from a treatment perspective. And once you get that, I think you're doing pretty well, you know? So
Totally. Yep.
yeah. And then it comes down to diagnosis, right? And I think from rotator cuff perspective, there's so many special tests, right? Are there any good ones you really like to hang your hat on for rotator cuff related pain?
Oh, geez. Yeah. I usually will look at like a cluster of some pain with the like external rotation testing in different positions, see if the, muscle contraction is bothering them. And then, it does seem like depending on someone's sensitivity and how flared up they are, like everything hurts, right? So whether it's Hawkins Kennedy test or a near test or, a painful arc, they're kind of getting pain with all of those things. I guess the more positive findings, I feel more confident that we're dealing with some type of rotator cuff related pain. But I usually do like to see pain with a manual muscle test, something like that. That gives me a little more confidence that, maybe we're dealing with a specific tendon pain. How about you though? What do you look for there?
Yeah, I think very similar to you, right? There's so many different tests for, shoulder impingement, subacromial pain, rotator cuff tendinopathy, whatever you want to call it, right? The ones I tend to be doing over and over again are usually resisted, external rotation, internal rotation, scaption, full can. If we're not provoking symptoms, I may take them to like 90-90 external rotation, internal rotation. Might do an empty cam test. I also like Hawkins Kennedy. Theoretically, we're compressing some of those cuff tendons a little bit, so I think that's good. I do think that from like a differential diagnosis perspective, so if I'm trying to figure out this person has like a standard rotator cuff related pain, subacromial pain, or they have a large or massive rotator cuff tear, then you're probably looking at, let's say, drop arm signs. So taking someone into 9 degrees of abduction or scaption, can they hold that? Do they get a big shrug? Lag signs, so take someone into external rotation. Are they able to hold into that position? Do the same thing for internal rotation, hand behind the back, lift off. Can they maintain that? Because if they have a large or massive rotator cuff tear, then we're starting to think about, does this person need a surgical consult or not, right? We'll talk about that in future podcast episodes, but at least from a diagnostic perspective, we're trying to figure out what they have and how bad it is, right? So I think the next important thing to discuss after you've gotten that diagnosis, so you think this person has standard rotator cuff related pain, you ruled out other things, and also you don't think this person needs to go see a surgeon immediately to get a second opinion, or you don't think they have like an acute rotator cuff tear or shoulder dislocation where they need that consult right away, is to modify your lifestyle, right? And when you look through some of the rotator cuff related pain research, oftentimes this is included in the patient education section, right? So they'll try to educate patients on how to modify their lifestyle so they don't continually aggravate the shoulder. And I've gotten this from Mike Reinold. He tells this to patients all the time. So if you're walking around, you have a rock in your shoe and it hurts, you can take some ibuprofen and it'll make your foot feel a little bit better, but you're still walking on that rock, right? Modifying lifestyle and later on, like training in the gym, is going to help to take out that rock so you don't continually irritate the area, right? So basically, we have to figure out what's kind of aggravating the patient. So that could be like putting on a jacket or sleeping positions or potentially some sort of manual labor or putting things into the cabinet, right? Overhead work in general. And one of the big ones I hear a lot from my rotator cuff related pain patients, and it's winter in Boston right now. So fortunately, get a lot of patients that'll slip, slide, hold themselves quickly with their arm on their calf themselves, and that can really hurt. So these folks will just kind of re-aggravate the shoulder over and over again just because they're having these little mini falls. So I think it's really important that you just talk to patients how to modify these, put the jacket on with the other side of arm, finding sleep positions that feel good. So typically maybe that's on your side, painful side up, pillow basically underneath the shoulder or kind of wrapped around, right? The arms, also sleep on the back sometimes feels a little bit better. Modifying any sort of work activities. Oftentimes this is tough, but seeing if you can like stand on a stool and do things more at shoulder level as opposed to reaching overhead, that type of deal. What are your thoughts there, Kevin? Anything to add from that perspective?
Yeah, totally. I think those are all things that we hear all the time in people with shoulder pain. But I would say that as I've gotten a little further in my career, that's one thing I feel like I'm getting better at that we don't often think about as a new grad PT. A lot of times we're so interested in what we're finding and what we can give to the patient that we don't always do the best job at auditing their lifestyle and what things are really bothering them. Which I think, they're coming to you with a certain set of pain problems, and they are really hoping that you can help them with those specific pain problems. So diving into with the patient and getting more information about what specific things really hurt. Maybe some of those things like sleeping is really a difficult one for me because the person only has so much control of the position they're in while they're sleeping. But all the other things, if we can show them something as simple as how to put on their jacket with a little less pain, and other lifestyle things, if there are small modifications, it's almost more of what we can help them modify and what we have to take away early on than giving them specific interventions. So I think doing that audit and educating the person, it means a ton to them, and you can really reduce someone's pain by, like Mike would say, take that rock out of their shoe early on.
Yeah. Anecdotes, right? But I hear that all the time. And I tell that to patients a lot. If you can just stop doing the things that aggravate this, you're going to feel way better. So you can have a really big drop in pain, a lot of buy-in early on, just because we're removing the things that are kind of aggravating the shoulder. So I do think that's really powerful. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. And now back to your learning. Next thing to think about, and this is kind of related to my folks that like to train in the gym, which is, most of my patients, which I'm blessed to have, is you're probably going to have to modify your training a bit, right? And I think this has to be with what actually hurts. And I didn't say this with the modifying lifestyle, but I just think you have to modify things that actually aggravate the area. You don't have to spend a ton of time trying to modify things that don't aggravate the area, right? Sorry about that. So one of the thoughts is like, I have this rotator cuff related pain. I should probably stop everything in the gym where I'm doing stuff overhead. And it's like, do you actually have to do that? Because sometimes overhead stuff feels decent Whereas let's say something like a bench press is what causes most of your symptoms, right? And oftentimes like an overhead press might hurt, but a pull-up feels fine. I'm not going to stop people from doing pull-ups, right? I will say the big offenders for most of my gym goers are usually going to be bench press and overhead press. And it's generally just press variations in general. I'm using the word general a lot, sorry. And also has to do with heavier loads. So when folks go heavy on bench press, when folks go heavy on overhead press, tends to hurt more. And with tendon issues, usually light, slow stuff feels decent. And then as you start to increase the speed, as you start to increase the load, things start hurting more, right? And then from a modification standpoint, I actually want to try to keep these folks exercising as much as possible and try to keep their program as similar as possible as what it's supposed to be, right? So if someone's supposed to be doing heavy sets of 5 in the bench press and that doesn't feel good, and all we have to do is, let's say, reduce the RPE, the rating of perceived exertion, and raise the reps a bit, and they're doing sets of 8 to 10 and they feel really good, then let's keep that, right? I don't want to tell them to stop bench pressing. Let's keep them benching. Let's keep them working towards their training goals as much as possible. 2 reasons for that. So one, you're going to prevent deconditioning. So one of those big problems with, I would say, the old model for physical therapy is that basically you stop doing everything that hurts, right? And then folks get real deconditioned. And once their pain goes away, they kind of ramp back into training, which is not a bad way of doing it. But I think you get a lot of deconditioning from that standpoint. The other piece is that exercise helps you heal. Like there's a ton of research showing that when you strength train the shoulder or strength train other parts of the body, it actually makes you rehab and get better, right? So like when I take away strength training, I'm potentially decreasing my outcome, and patients are going to hate that. They come to you because they want to bench press. So if you're like, hey, your shoulder hurts from bench pressing, I have a solution. And it starts with bench and ends with press. You're going to be like, whoa, I can keep bench pressing? I'm like, yeah, man, it's actually going to help you out, right? What are your thoughts on that?
Yeah, totally. I think this is one thing, again, as an insider here, and I see you treat patients all the time, that you really excel at. And I think the message that you've been putting out in regards to this is hopefully increasing the level of care for physical therapists. There are so many patients that will come in with shoulder pain that will say, I know I'm not supposed to lift overhead. I was told by my physician said, I should never lift overhead again. I'm just going to horizontal press for the rest of my life. And very often that's totally untrue. So one thing Dan will do with his patients is keep them training at the highest level possible. And I've seen you sometimes, take out a sheet of paper and write down all the lifts that someone does and have them rate on a scale of 1 to 10 how hard it is for them or how much pain it's giving them. And, whether you take their word for it there or you go into the gym and try some movements, for those lifts that are giving people over 5 out of 10 and pretty significant replication of symptoms, instead of just totally cutting it out, Dan might go from a bench press to a floor press. And maybe we find that 6 or 7 out of 10 pain is now down to a 3 or 4, right? And it's warming up and they feel a little bit better. And then that person leaves very excited because they can still floor press. They can still do the things they love in the gym. So, I think that's one thing that is really indispensable that as PTs, we should excel at. We should be able to find modifications for these patients. And, it's something that I see you do day in and day out. And I think your patients really appreciate it.
Wow. When I brought Kevin on to this podcast, I didn't realize I would get so many great compliments.
That's right, man. I'm here to feed the fitness pain-free ego.
I'm not going to say I don't disagree with you because this is my thing. So yeah. All right, cool. Nice. And I think the next kind of natural question kind of becomes what's okay to do in the gym and what's not okay, right? And I take a lot of my ideas on this from the pain monitoring model, right? Which essentially means that if your pain is less than a 5 out of 10, and then basically that night, the next day, you retest a certain movement, right? Let's say it's like a push-up or something, and your pain is kind of back to baseline, then those movements are probably okay. And if you haven't heard of the pain monitoring model, basically this has been studied in a variety of different tendons, but Achilles tendon is a big one. Patellar tendon is another big one. But you'll see it all over the place with research. Generally speaking, if you have someone continue, let's say, running and they have Achilles tendon pain, right? And it does hurt when they run, but they're not limping and their pain is minimal. You compare that to another group that doesn't run and they'll just do exercises for the Achilles and they're not allowed to push through pain. What happens in the long term is, generally speaking, they have the same outcomes. They both improve, right? And in some studies in the short term, essentially the group that was allowed to push through some pain gets better faster, right? And the other term you'll hear a lot of in research, particularly in the rotator cuff, is the word tolerable, right? Jack Hickey uses this word a lot in hamstring strain rehab too. So if the movement feels tolerable to the patient, then it's probably okay, right? I just often tell patients that this is an experimental process. We're going to do our best at guessing the movements that are right for you. And then over the course of time, you give us feedback about what ends up kind of feeling good and what doesn't. And sometimes you really have to talk to the patient and try to figure out if they're the type of patient that pushes too hard or the type of patient that doesn't push at all, and you need to give them a little bit more, right? I was talking to a patient that had ACL reconstruction with me a year or two ago, and she's the type of patient that just like blows through pain 100% and just never like listens to her body at all. And sometimes these patients are nice because they're never complaining about their pain, right? But then it's also frustrating because it's like, man, you just gotta just be a little more mindful of this, right? And just like, if your body is really giving you the signal that it's hurting a lot, we can't ignore it because it's trying to tell you something, right? Then you have the other end of the spectrum where you have these folks that just like any sort of pain whatsoever, like, whoa, we need to stop. We need to stop doing this. I'm tearing my rotator cuff. I'm severing my spinal cord, right? We hear those things. So you just have to kind of educate those patients, let them know, like, nah, you're safe. It's okay. Not too big a deal. And that's always tough because you're trying to give them a little bit of hope and confidence in their body without trivializing the condition. Because if you do that, then you lose a lot of empathy, and then folks just feel upset. So that's just something you have to navigate. Where I think like communication skills become important, and just reading that patient and just trying your best to figure that out. But what are your thoughts on that? Do you have any clinical pearls from that perspective, Kevin?
No, that's great. I think it does take a little confidence in your diagnosis to roll with that 5 out of 10, right? If we're talking about rotator cuff related pain here, so with that diagnosis, that's totally fine. I think you do want to be pretty good about making sure you rule out like that cuff tear, or and other pain problems, like if someone's dealing with a bone stress injury or joint effusion. We're a little more cautious with that 5 out of 10, but if we're following that pain monitoring model, was that Silbernagel that came up with that?
She actually wasn't. She was one of the first. So that article what she did was like 2006, 2007, and she mentioned the pain monitoring model in that, and it was from
Mm,
another study. And I always feel bad because I forget the author, and
yeah.
I really am just like using their model and like pretending like I came up with it, and I didn't, and I don't remember the original author, so it's
Yeah,
bad.
yeah. We use it at Champion all the time, and we talk to the students about it, and we talk to our patients about it. So I think once you're confident in your diagnoses, and even if initially you're not super confident in it, and then you find over the course of a week or so, the person is at that maybe threshold of 4 or 5 out of 10, but then they find that that night, the next day, they're kind of back to their baseline. Then you kind of know you're trending in the right direction, and they're happy that they can keep training. One other thing quick that I know you talk about a lot and that we try to talk about with our patients is, like you said, you could either work through no pain and this might get better over time, or you can keep doing the things you love that are good for your health. And, maybe your pain will get better over time, but if you completely stop training, your other health markers might plummet, right? You might start gaining weight, your mental health might not be as good. So it's always important to weigh the pros and cons of working through some pain. And I think most of the people that come to see us, we're in a setting where people are extremely active and they'll do almost anything to work out. And a little pain, as long as they know it's not making them substantially worse, they're totally cool with it.
Yeah, I agree 100%, right? We want to keep people exercise as much as humanly possible. My personal opinion, but again, you don't have to, right? It comes down to your style as a physical therapist, but that's just what I prefer. All right, boom. Next step is to apply a progressive strength program. And this is a little bit of a pet peeve to me. And I think it's just a kind of a cultural thing from the strength training world, right? So I guess two stories. Just the other day, I put out a Instagram short, which never has great context. And they just blast it out to a million people. And YouTube is like a cesspool sometimes for people with comments. They're just like mean or they're just mad about whatever, right? And it's funny because one person responded with something like, "Oh, number one test for shoulder impingement is pain with pressing overhead. If you want to wreck your shoulders, you should do overhead pressing variations, right? With shoulder impingement. Like, never hire this trainer, basically, to me. And
Yeah.
like, my first thought was like, do I even respond to this? Like, I don't think there's going to be anything good that comes from this. You know what I mean?
It's so tempting. You got to
Yeah. But
respond.
yeah, well, there's just like, and I don't think coaches should blow through pain in the gym with their patients, right? But I think the big thing is that folks are so afraid to load anything that's painful, right? And I think one of the pieces of information that you'll hear a lot on like Reddit forums, YouTube, you see this from a lot of trainers, is that if it hurts the press, you should stop pressing and just do lots of rowing, right? Do the opposite because that's going to balance your shoulder out, right? And I think a lot of the shoulder balance came from the baseball world, right? We work with a lot of baseball players. With baseball, it's interesting because when you throw a ball, you have to accelerate it with a certain set of muscles, and then you have to decelerate your arm afterwards with the opposing muscles, right? So it's like if you don't have really strong opposing muscles, then you're basically overpowering, right, the backside of the shoulder, which potentially leads to problems. And then that's one of the reasons why folks get limited internal rotation, they get weak in the, you know, external rotator, so on and so forth. If you think about weight training, you accelerate the bar with one set of muscles and you decelerate it with the same exact set of muscles, right? Right. It's not like the back of the shoulder kicks in during the lowering portion of the lift. So I think it's just like a misunderstanding of the actual biomechanics of it, right? And the other piece I will say is that if you have Achilles tendon pain, right? What's the number one treatment for Achilles tendon pain? Is it tib
Calf
anterior
raise.
raises? What do you
Yeah.
do?
Calf raise. Load it.
Yeah, you load it, right? So it doesn't make any sense to me that when you have shoulder pain in the gym, you like stop pressing and you just row. Like,
Such
all
a
right,
good
we're
point.
gonna not target the tissue that's irritated. So I take the exact opposite stance, right? Basically, I want to continue targeting the irritated tissue with exercise, and I think that actually ends up being a really positive thing for your patients from a psychological perspective. Because you're like, hey, when you feel that pain, it means the medicine is going in the right area because the exercise is the medicine, and you're actually doing the right thing by exercising that tissue. So it kind of flips their mental a little bit. And again, you have to just read the patient. If you're one of those patients that blows through pain, that's the last thing you want to hear. So they're like, great, I'm crushing it. It's like, no, you're crushing your rotator cuff. You need to back off a little bit. Right. But generally, I like to target the painful tissue. So you aren't during your clinical examination. If it hurts with, let's say, external rotation or scaption or abduction, then you probably want to start with exercises to kind of do that. Right. Any thoughts, anything to add from that perspective?
No, that's really interesting. I guess I never thought of it in that lens of the weightlifting, right? It's you're using the same set of muscles with the whole lift. So you got to start loading it. And our mutual friend Chris Johnson has a saying, load the tissue with the issue. And I think that's great. I try to keep that in my mind all the time. So yeah, I think that's awesome. So would you say if you were working with someone, say anterior shoulder pain, bench pressing, and we were finding that all press variations initially were very flared up, say this was an acute rotator cuff related pain, you cut that out temporarily, and then as soon as they feel like they're back at that threshold where they're not flared up for days after pressing, you're adding it back in. Do you load up rows a little more early on um, if the person is a little too reactive with pressing still? Or are you doing that maybe more rows, but you're still giving them exercises for their pec or anterior deltoid or something like that?
Yeah, both. And I think it depends on the patient's preference. But let's say they have an upper body training program that's twice a week, and it's got about an equal amount of pressing as rowing exercises, which a lot of programs have. Basically, I'll just modify the presses and continue all the rows. If rowing feels fine, I mean, there's a few folks that rowing hurts as bad or worse sometimes than pressing. If that's the case, you're gonna have to modify your rows a little bit.
Yeah.
But largely, I try to keep in as much of both as possible. And if their pain is so bad with pressing that I have no modifications that work well, which doesn't often happen. Like I'll even just like throw things in like, because I find that if you even have a really, really irritated shoulder, we could probably throw some BFR cuffs on you and do some like really light dumbbell press. That's usually
Mm,
tolerated pretty dang good, even if you have a really irritated shoulder. Or maybe you can even do like BFR with some of the rotator cuff exercise or something along those lines. It's usually something you can do to maintain some of the pressing as much as possible. But if I have to pull out some of the pressing, I might replace it with some rowing. And I think from a psychological standpoint, that feels pretty good to the patient because they can actually do a little bit more. So maybe they're overemphasizing their pulling muscles now because it's something they still can do. It's like a nice training effect there. Maybe they're focusing more on building their upper back or something along those lines, which is nice from a psychological standpoint and a training perspective too, right? So
totally. Yeah. So maybe keep training volume, overall training volume the same, and then whatever movements fit for them at that point in time.
yeah, I think a lot from the mental standpoint. Like people come to me because they want to continue training. So if I can keep that training window like the same exact challenge and length of time as possible and work towards the same goals, that's a big win for me, right? So
Totally. Yeah.
yeah. And then from there, you start with the basics. So I always tell patients it's super boring to do scaption, external rotation, so on and so forth. But I really think that's kind of like the best medicine. I almost always start there for folks that are highly irritable. For folks that aren't highly irritable, you can just start with higher level stuff, right? There's no rule saying you have to start in phase one necessarily, but those are the ones I tend to start with early on. And you can also start with isometrics if someone's not doing well with isotonics, right? So you got a lot of options there. And in terms of progressions over the course of time, I think two things. So for one, you can increase the loads, right? The speeds of movement or just challenge of the exercise. So choose harder exercises. But I think the other thing that becomes really important is now specificity. It's like, what is your athlete or person in the gym, whatever, trying to get back to, right? If that's, let's say, heavier bench press, because that's what hurt before, then you probably want to choose exercises to help facilitate that, right? So, using bench press by itself and just slowly increasing the load over the course of time, or using variations that are maybe a little nicer on the shoulder. So, maybe like a Swiss bar press, dumbbell press, something like a Spoto press or a floor press where you're cutting the range of motion, adding load over the course of time, just trying to just make it super specific to whatever the athlete's trying to get back to. So, what are your thoughts, Gavin?
No, awesome. Yeah, I think you nailed that. I think finding the most they can tolerate, keep them training, uh, it will keep them happy, right? So that's great.
I included some honorable mentions because as physical therapists, we love exercise, but we do other things too, right? And maybe it's not so popular on social media right now, but I do mess around a little with manual therapies, right? We do some laser, some shockwave, right? Some modalities. Um, I did a little lit review just to see the effect of some of these additional things, right? Manual therapy being one of those. And it's really interesting, right? And it's funny. I was looking at this stuff just last night. Um, but you'll find these big kind of systematic reviews, meta-analysis that show kind of no difference between manual therapy plus exercise versus exercise alone. So big study in sports health. I'm going to mess this guy's name up. It looks like a Greek name, Paraskevopoulos, Sports Health
Nailed it.
2023. It's a pretty recent article. No difference between groups in terms of pain and function. This was a longer term outcome, right? Peters et al. In 2020 gave a strong recommendation regarding the inclusion of manual therapy in the initial treatment phases. And I looked through that article a little bit, and largely using manual therapies were helpful in the short term. So either immediately after exercise or within the first 3 weeks or so, right? And it's funny because I was looking last night and there's just a study published in JOSPT, and I'm going to do a video about this, but I was looking at manual therapy plus exercise versus exercise alone, and actually showed a short-term and long-term benefit of the manual therapy. And it was a randomized control trial just published in January of 2024. So what I will say is that this research is super confusing, right? And who knows what you're supposed to do. What I will say is that I personally do use manual therapies for a lot of my patients, not all of them, but I will use it with my patients with shoulder impingement, shoulder, subacromial pain, whatever you want to call it. And it really depends on the patient. I don't give it to all of them, but some of them I think they can really benefit. And at least the techniques they use in these studies, largely you'll see joint mobilizations, posterior, inferior, some anterior, some long axis distraction, I'll do a video on these at some point, so it makes a little more sense. They'll do some specific soft tissue stuff, so scalings, SCM. They'll work on the pecs. They'll work on the posterior cuff, that type of thing. You also see some mobilizations for the spine, so cervical spine, CT junction, thoracic spine, mobilizations and manipulations. So, kind of all over the place. What are your thoughts, Kevin? You use manual therapy, right?
Yeah. My thoughts here are it's very confusing, the manual therapy research, right? I think like you just noted, that new paper that came out, that randomized controlled trial, I did see that. And like you said, it did show some improvement. I can't remember all the details right now, but that was in contrast to some of the meta-analyses that have showed that, it's not as effective, right? So the way I try to handle it is on a patient by patient basis, right? So some patients come and see us and they just want a program that they can work on their own. Maybe they check in every several weeks or every month and we update their program. Obviously, that person is not getting any manual therapy. Some other people, the way I try to go about it and the way I talk to the students and try to have them go about it is if someone's coming in to see me, I want to check some baseline things every time they come in. So they come in, let's lift overhead, let's see how your mobility looks. Let's see if there's any pain. So you have a pre-test and then you do whatever manual therapy technique you're best at. So I think that's one thing is for a lot of these, the benefits are, or the technique can be pretty non-specific, right? So maybe we're doing soft tissue. Some patients love dry needling. Other patients like tool work. Maybe we do whatever modality we want to work on, and then we recheck that baseline. And I think that's huge because if the person is not showing any change and they don't really know why you're doing the manual therapy in the first place, it's totally not worth it. They might just think like, why am I coming here, wasting my time in person? We didn't check anything. I don't know if it's helping. It feels good. But other times I think patients, you can see an actual change, right? Whether that's in range of motion. I'll have, like you said, we treat a lot of baseball players to champion. So maybe they were throwing, their shoulder feels pretty crappy. They come in, we do some soft tissue, they throw again, and they feel amazing, right? So whether that's what a mechanistic thing that's happening or, there's so many things that go into it. Psychological reasons people feel better after manual therapy, that gets very confusing. But if you have a pre-test, an intervention, and a post-test, and the person is feeling better, then I will continue to use manual therapy. I'll just be very cautious about how I explain what I'm doing and why it's working. I try to be as honest with the patient as I can and, not tell them that it's breaking up scar tissue or anything crazy. I just try to tell them, well, we looked at this one thing, we did this and you're feeling better. So, there could be a bunch of mechanisms why, but let's roll with it for now. And I'll try to always show them a way they can replicate that on their own if that's possible.
Yeah, good point, right? They can use a foam roller, they can use a ball, they can kind of work on that stuff on their own, right? One thing, I agree with you completely. One of the things that, like as an early career professional, a little bit, newer as a clinician, I was kind of a bit of an evidence-based Nazi, like just very extreme. And I think what ends up happening, and if that is your style, and we're lucky because we're out of network providers, so it's not like we have to, argue with insurance companies about what we do. I ask a lot of questions about what the patient wants, right? And I think a lot of what I do is dictated by their needs and desires. And as long as they know that, hey, you're probably going to get better long term with manual therapy, the same rate as just giving a couple exercises, that's fine, right? I think the other part is that some folks kill, right? I had a patient that came in the other day and she has tennis elbow and it kills. She feels god awful. And she went to her doctor and doctor's like, it'll probably go away in time. Don't worry about it, right? And she hated that. And she just felt like completely invalidated by that. And she came in to me and I was like, well, doc's right. In months to, sometimes up to 9 months or so, some of these studies will show for tennis elbow, it'll probably go away without doing much anything for the average person. But like if we treat it, we know it gets better faster. And I did some manual therapies, gave her some exercises, and I did shockwave on her elbow. Next day she texted me, she's like, oh my God, I feel so much better. Right. And it's like, that's what she wanted. You know what I mean? And like, I'm not telling her because she's like, oh, should I come in 3 days a week for a shockwave? I was like, no, I don't think you need that. Like, you don't need to do that. I mean, would I make more money if I said that and made her believe that? Yeah. But I don't do that. I'm not trying to, you know what I mean? That's not what we do as physical therapists. But the other part is like she got a lot of benefit from that. And I'm not going to hold that from her. And that's completely what she wanted. So I think that was a big win, right? Yeah.
Oh, that's a great point. Yep.
And this kind of segues to the next one is shockwave. So we got a extracorporeal shockwave machine at Champion. We're pretty dang lucky, man. We got some cool toys, right?
Got everything, man. I know we're so spoiled.
I know. I wanted this for a while because I was reading all these studies about shockwave being helpful for these like, varied different types of issues, right? Like bone stress injuries, like Morton's neuroma, strain injuries, tendinopathies all over the dang place. So, I've been trying on a lot of stuff recently. And, it's funny because it seems to be pretty beneficial in a lot of areas. One of which not so much is for rotator cuff related pain, right? And I was actually talking to one of my patients who's a physiatrist who does like PRP injections and prescribes a lot of shockwave. And I was like, why do you think this is? A lot of other tendons do well. What's the deal with, the shoulder? And one of his responses I thought was pretty interesting is that I think we have a tough time with differential diagnosis in the shoulder. We mentioned it previously because if you have like anterior shoulder pain, it could be your rotator cuff, could be your biceps tendon, subscap, right? Latin teres is in that area, pec minor, pec major. There's so much stuff that creates anterior shoulder pain. And we're just going to like blanket try to hit that with, shockwave therapy. Are we actually hitting the right structure? And I think you see the same thing with PRP in the shoulder too. It's like kind of hit or miss in terms of how it works. We know there's so much asymptomatic pathology. It's kind of like we might not be hitting the right area. Whereas the other parts of the body, we can be a little bit more certain, like, yeah, we are in the right area, right? Before I get your opinion on this, what I will say is that there's a bunch of studies that actually show that calcific tendinopathy in the shoulder does pretty well with shockwave. So if you have a patient that's not making progress, they go back and get some imaging and it looks like calcific tendinopathy, then they may actually do pretty well with other types of procedures like shockwave. So I think it's potentially still worthwhile maybe in the shoulder to try. The research seems to be conclusive for rotator cuff related pain from the studies I read. There's several of them. It doesn't work so well, but if they're dealing with calcific tendinopathy, may be beneficial. What are your thoughts? Any success with shockwave?
Yeah, I would say I haven't been using it for our patients with rotator cuff related pain. I think what you said, I kind of see with my patients, like the pain might be diffuse enough that it's not like an Achilles tendon where it hurts right here and it's a very specific spot. And again, I think if we have access to this thing, so if we're trying a bunch of things and their pain problem's not improving, we're lucky enough that we can go out to the gym. We don't bill for shockwave specifically, right? They're there for PT for whatever given amount of time. I might try it. I haven't tried it with rotator cuff related pain, but try it and see if they notice any improvement. You would probably be using the same type of strategy I use with manual therapy. So I'd want to get some baseline of the pain problem, do the shockwave and retest and see if it's improving their pain problem. Unless something were to come out and saying it was changing the tendon and it was making the tendon, quote, healthier tendon and it was accelerating recovery, I would totally use it then. But for strictly for pain problem, I haven't been using it for that.
All right. So we tease you that you should be doing some form of exercise in your patients that have rotator cuff related pain. I have a video for you that goes over my favorite exercises for folks that have rotator cuff related pain or subacromial pain. I'm going to leave a link in the corner. You should click on that and I'll see you on that video. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.